So we recommend asking it routinely for people aged 75 or more. We know the prevalence of dementia in that population exceeds 10%. So it's a pretty high prevalence. If we look at cognitive complaints longitudinally, they correlate with future dementia. So there are a number of studies with follow-ups about 13 years showing that cognitive complaints did correlate. However, if we look at cognitive complaints cross-sectionally, so at any point in time, they correlate much better with neurotic personality traits, with depression, with anxiety, with more physical problems, with poorer quality of life. So it's tricky. We shouldn't be seduced into thinking somebody who's cognitive complaints definitely has dementia, but then again we shouldn't ignore it. And often it's long-term follow-up that will decide. But in the first instance, we need to take it seriously and ask some more questions. So just a couple of preparatory comments. What is dementia? Dementia is an umbrella term to describe a syndrome. It doesn't describe a disease. The commonest question I have is what's the difference between Alzheimer's disease and dementia? And I explain Alzheimer's is a type of dementia. There are many types defined by the causes or the pathology that's happening in the brain. About 50% of the dementias are caused by Alzheimer's disease, and maybe another 20% vascular dementia. But even that is not as clear-cut, because if we look at people aged over, say, 75 or 80, most people will have mixed pathology in their brain. It's rare to have single pathology in the old. And so we give these figures as rough guides as the dominant pathology. But in fact, the older the person, the less likely there'd be a single pathology. The third most common cause is Lewy body dementia. And I'll describe some of the clinical features of Lewy body because the management is somewhat different. The fourth commonest cause is frontotemporal dementia. When I was going through medical school, we were taught that was Pick's disease. That term has pretty well been abandoned, even though Pick actually preceded Alzheimer's. They were both in Germany at the same time, working in the same place, and both very prominent figures in the whole field of dementia. So the definition of dementia, by the way, the definition is about to change, but this is the definition we're still working on, is a loss of memory and a loss of some other cognitive function. So impairment in two cognitive domains, memory and one other. The DSM-5 is coming out this month. That's the new Diagnostic and Statistical Manual. And in that one, it just requires one domain, and it doesn't require memory to be the specific one. It can be any one. That really, I think in general practice, is not critical. The more important thing is there is cognitive impairment, and it interferes with function. So the person can't do the things they used to be able to do on a day-to-day basis. The third element is that represents a decline. If somebody's born like that, that's intellectual disability or developmental disability. But if someone develops a decline in that, that's what dementia is. So three elements: cognitive impairment, functional impairment, and represents a decline. And then there are some exclusionary clauses. So it can't be caused by a systemic disorder. It can't be such as, a psychiatric disorder such as depression. The prevalence is increasing. And why is that? Because there are more older people. We're an aging society. We currently have about 13% of the population aged over 65, about 2% aged over 80. We have about 4,000 people aged over 100 in Australia. Our 13% people aged over 65 is going to be 25%. We're going to double in a generation. That's why the government is so worried about superannuation, and you hear all the politics that are happening, even in the budget speech reply last night. The prevalence increases with age, and the aging is increasing. That's the epidemic. The prevalence increases exponentially with age. So it's 5% of people aged over 65, or later figures even higher, oops, sorry, and 20% of people aged over 80, and 30% of people aged over 90. We're doing a study of people aged over 95 in Sydney. We call it the centenarian study, so people who are over 100 or near 100, and we're finding rates in those people of 50%. 50% of centenarians don't have dementia, which is the positive side. In Australia, estimates are that there are about 1/3 people with dementia now. And that's set to almost triple by 2050. There'll be just under 1 million people. So, rough figures. If you've got 1,000 people in your practice, realising that older people are overrepresented in general practice. So let's say you had not 13% of your population, but 20%. So that would be 200 people aged over 65. Roughly, you would have at least 10 people with dementia in your practice. And as you get older, your patient population tends to get older. Your patients age with you, as a rule. So for every person with dementia, there would be at least 2, maybe 3 people with pre-dementia, so-called mild cognitive impairment. And if you have an older practice, those numbers will increase more. Around the world, it's estimated there are 35 million people with dementia, and that's set to triple again by 2050, and 2/3 of those will be in developing countries. China, India alone will account for half the world's population with dementia. Almost half the world's population anyway, but particularly with dementia. In Australia, as I said, we're going from, those figures are a bit out of date, about 0.3 million now to about 900-something thousand. And just a separate note is Aboriginal people have a much higher rate of dementia than non-Indigenous people. Some of you may have seen the story in the Sydney Morning Herald yesterday about a study led by Tony Bro, showing, I think, about 5 times the rate in Aboriginal people. May be related to early childhood experiences, or even prenatal and perinatal and postnatal experiences too. Just a word on mild cognitive impairment. This is something which is somewhere between normality and dementia. So this is the concept. People are normal and they have to transition through a phase of loss of cognition before the cognition actually interferes with function. There have been about 3 studies come out in the last year which have demonstrated that Alzheimer's pathology builds up for 25 years before the dementia syndrome becomes manifest. So the way I conceptualize it, if you think about an iceberg forming under the water and gradually getting bigger and bigger and bigger until the peak just pops out of the water and is visible. And that's the clinical picture of dementia. Well, that build-up of the iceberg, or the pathology in the brain, is taking that 25 years. And there comes a phase where people have some cognitive difficulties but are still functioning normally, and that's called MCI. So the definition is not normal, not dementia. There is some impairment on cognitive testing, so objective impairment as well as subjective complaints. But the basic activities of daily living, general day functioning is still okay. Mini-mental state, still okay. It's more detailed cognitive testing that reveals the deficits. On all measures, MCI appears to be intermediate between normal and Alzheimer's disease. If you look at neuropsychology, neuroimaging, neuropsychiatry, this is behavioural and psychiatric symptoms such as apathy, personality changes, depression, aggression, and neuropathology. If people die with MCI from another cause, they will have some of the pathology. We can now do PET scans which image the amyloid in the brain. This is with a compound called Pittsburgh B, or PIB, and it shows the amyloid. And some people with MCI will have quite a lot of this amyloid, and some won't have any. And that fits, thanks Alan, because some MCIs actually revert back to normal. Some stay stable and some get worse. In people coming to a clinic, about 12% per year will progress to Alzheimer's disease. In a population sample, like the epidemiological study I just told you about, then that's about, it's only about 2%, and the reversion rate's much higher. So why the fuss about MCI? Well, there are these different rates in progression, but it may be that if we can pick up people earlier, some of the new drugs that are being trialled for Alzheimer's disease might work. Because we've been doing drug trials at Prince of Wales Hospital in Randwick for 20 years. We still don't have a drug that can stop the disease. And the thinking now is that maybe that we're doing the trials too late. By the time the iceberg has emerged from the water, the build-up of pathology is so big that it's too late to be able to stop the disease progression. It already has the momentum. So, the first step was to take the complaint of memory loss seriously. The second step is to think about cognitive decline in older people and just ask some questions. Should you be screening people aged over 75? That's controversial, and I'll come to that.